I have worked with what was started off as the Nursing and General Practice programs. That was actually a program to encourage doctors to employ nurses, and funnily enough we got a lot of resistance back in the beginning, but we managed to turn that around and now they can't get enough of you, so that's a great thing. So during that time there I also did a lot of work with helping general practices become accredited, and then of course an offshoot of that was teaching them about infection control, so that's why I'm talking about these topics today. Let's get going. Okay, there's your learning objectives, and obviously it's and these two sessions flow into each other, so the learning objectives that you're looking at there cover both of the both of the ones we're talking about pretty well. I'm not going to read them out to you because we've got a lot to get through, but as you can see we're going to talk about accreditation and quality in general practice. Okay, so the RSC GP Standards, there's just been a new 5th edition of standards brought out. They were finally sort of released in November, but there's been a fairly long phasing in period. So some of you may be working in services that have already been accredited under these. Others of you that have accreditation coming up will be looking at these new standards now and what that means. Let me just go back one. No, that's the one I'm looking for. So you will hear a lot of, oh, well, that was in the 4th and what's in the 5th, because for practices that haven't been accredited under the standards, they'll be wanting to make comparisons. But let's go into a little bit about accreditation. It's actually voluntary for general practices to get accredited, which is a bit of a surprise because you think that it's, you know, your fish and chip shop's got someone looking at the quality and how that's managed, but there's nothing in general practice unless they choose to engage in the accreditation process. And realistically, we really want to try and at least have about 85% of practices nationally that are accredited to maintain a sort of consistent quality and approach to work in general practice. It's peer assessed, which means that the people that are assessing them, you have a survey visit, and the people that come in for that survey visit will be usually a GP and usually a practice manager or a nurse, or what they call the non-GP surveyor. So if any of you have an interest in accreditation and quality, well, perhaps think about becoming a non-GP surveyor. It's a really good way to actually have a look at what goes on in other services. These are based on, it's 3 yearly, so, but we don't want to see practices rushing in the last 6 months of that 3-year cycle. We actually want it to be something that builds up and is maintained and worked on for the whole 3 years, but obviously there's a lot of extra work to do as you're coming up to it. They're minimum standards, so the standards that are out there are minimum. So most practices do very well against them, and most practices actually exceed what the minimum standards are. And so there's no pass or fail. If you don't meet all the standards, you'll be given an opportunity to submit or show evidence of how you have met them. If you do really badly, you might need a new survey visit, and that will cost the service money, so that's not an ideal situation to be in. And there's no spot checks. Nobody comes and checks in between. You do it and then you come and get reassessed in 3 years. So there's, let me just see, we'll go to the next slide. Okay, there's 2 bodies that do the accreditation. One of them is AGPAL and one of them is GPA. So the standards are developed by the Royal Australian College of General Practitioners, and then either AGPAL, or sorry, they've changed their name to Quality Practice Accreditation instead of GPA, they're now QPA, which I have to learn to say. So the standards are written by the RSCGP, and then these 2 bodies are the ones that are licensed to actually manage the assessment. So therefore, you need to find out who is the body that's accredited your service that you're working for, and make sure that you're able to link into all the resources and information that they have to assist you along the way. Just a quick show of hands, who's working in a service that is accredited? Pretty well all of you. Who doesn't know? Who's not sure if their service is accredited? Okay.
Sorry, I'm just new.
You're just new, so that's all right. Yeah. And, you know, really, these logos will be stuck somewhere on the front door. But, you know, if you're a consumer or you're not in the know, you wouldn't walk in and think, oh, that means that I'm going to a service that's got some quality in place. It's a bit ambiguous, but anyway, that's what you need to look out for to see which service has accredited the one that you're working for. Okay, it's always useful to have a little bit of insight into the reasons that practices get accredited. The reason that's useful is because if you're trying to put forward some ideas, it's helpful to be able to work out in your service, well, why has my service got accredited? So then you can kind of slant your ideas to appeal to their reasons. So there was a poll done a few years ago, and 49% of services said they got accredited so they could access the Practice Incentive Program. You might have already talked about the PIP program in some of these sessions today, during the course that you've done. So as you know, it's a program to give incentives for meeting certain objectives and targets, and it can be worth quite a bit of money to services, so that obviously motivates them to get accredited, because accreditation costs money as well, so they like to be justifying that spend by getting something else out of it. 41% do it to achieve excellence in quality patient care, so isn't that reassuring? Gives you a nice warm fuzzy feeling about the industry we're in. 8% do it to meet the requirements as a teaching practice, and 2% indicated other, which is probably just the 2% that did know the answer. And other reasons that I think weren't asked on this but do have a big impact, often their medico-legal insurance premiums are reduced if they're working in an accredited service, and also it helps them attract healthcare professionals and especially doctors. So if your service is having trouble attracting doctors, then promoting that you're an accredited service will often help with that, because doctors like to work in a service where they know there's some systems and quality, just like everybody else. So I would highly suggest as a nurse, if you ever do change jobs, you actually work for services that are accredited, because sometimes it's a bit hit and miss in the others. The reasons that they often don't get accredited is not always because they've got bad quality. Often it's because it's a solo GP who's going to retire soon and just thinks it's not going to make any difference to how I work and what happens in my business, but they do still want to maintain good quality. Sometimes it's because they're a new service and they are just in the process of working towards accreditation, so they might be registered for accreditation. And sometimes it's because they might offer a service like a skin cancer clinic that just doesn't quite meet all the criteria, so they find it a little bit difficult to see how they can meet all the accreditation requirements, so they've opted not to get accredited. Okay, this is what the new RSCGP standards look like. They have a core module, a quality improvement module, and they're the same across any service that is being accredited, and then they bolt on a module specific to the industry. So for this industry, they bolt on the general practice module. Just to give you a bit of an example of how that works, say we're looking at how their standards, the themes related to patients. Your core module will be talking about broad things like your patient's rights and needs, and then your quality module will be talking about getting feedback and actioning feedback from your patients. So again, it's a broad topic that applies to any health service. Then your GP specific module talks more about access to care and comprehensive care and things that you need to provide comprehensive care in the GP setting. So that's the sort of thematic difference of the three modules. And there's been a few new things added and new themes added. Usually the standards, they'll have a 4th edition, and then they some things are mandatory and some things which we call flagged, and some things are non-mandatory, so they're optional and they're called unflagged. But you'll find that generally something that's unflagged will become flagged in the next edition, but with this 5th edition they've actually put in a few new things that were not ever mentioned before, so that will throw and challenge some services. Mainly that's around social media. There wasn't anything mentioned before around social media. There's one around ethical dilemmas, which I think is giving everyone a dilemma because no one quite knows what that means or how it's going to look, but that's one of them. And one around business operations and management. There wasn't anything really covered in those themes before. What's still the same is obviously recognising teams and teamwork, patient safety, your clinical governance, risk management and quality improvement, etc. So those things are the same in all standards. Okay, why is it relevant to a nurse? Okay, actually accreditation provides a real opportunity for nurses to take on responsibility in the practice that they're working in and actually say, hey, I can help with this, I can do this. And by doing that, what it actually lets you do is affect change. You might have been going to your practice manager and your principal GPs and saying, I'd like to do this, I'd like to do that, falling on deaf ears. But if you can say, hey, I see we're getting accredited. If we did this, this and this would really help us with accreditation, you might suddenly find you'll get a shift and things actually do change and you can start to do the things that you would like to change. If you are a nurse that is involved in it, and you will be involved with it if you're working in any services that are accredited, there's some tips for where to get support, and the obvious place is make sure that you link in with your accrediting body. Ask for the password and make sure you can get on that website and have a look, because they have webinars, they have YouTube videos, they have lots and lots of resources already written for you so you don't have to reinvent the wheel. And you know, I'd suggest when you go back to where you're working, actually ask to have that access and see what's there, because you might be thinking, oh, we could do with this or we could do with that. Chances are it's already been written by someone else and it's posted up on those sites for you. And of course, with the new standards coming in, there'll be lots of opportunities to attend education about accreditation, and if you get a chance, I would suggest that you do that. I will talk more about some of the things you do down the track. Okay, now, when they come and do the survey visit for you, as I said, you've got your GP surveyor and your non-GP surveyor, and I think that while we've got everyone in the room, it's really good to rather than me just telling you about all the standards, because that just gets boring, we're actually going to play a little bit of a game and pretend that you're actually being surveyed. And we'll go through some of the sorts of questions that they would ask the nurse at the nurse interview. So they interview the nurse, they'll interview practice manager, they'll interview reception staff, GPs. They also look for evidence on the documentation. So this is what the surveyors are looking at. So we'll go through, obviously we can't cover all the standards in an hour, but we'll go through some of them to give you an idea of the themes that are covered and the types of evidence that they're looking for and how you would present that. So the other good thing about this is you can get ideas from everyone else that's in the room and here. You know, you think, oh, I might not be doing that, but that's a good idea the way they do it there. So let's pretend I'm the surveyor and I'll ask you some questions. So one of the first criterions that they ask about is clinical handover. Now you'll see on these new standards, it's got C 5.3. The letter at the start refers to which module that comes out of. So C means it's a core, it's out of the core module. If it's quality improvement, it'll have a QI in front of it, and if it's out of the GP module, it'll say GP. So this one's just so that you understand how they work. So if we're going to talk about handover, one of the questions that's on there is when and how do you ensure accurate and timely handover of patient care? Now the assessment method of this is via interview and document review. So if we were going to do the interview, if I asked you that question, who wants to have a go at answering when they do handover of patient care in their day-to-day? Who wants to tell me some stages and occasions of handover?
To a doctor, like you've got someone coming with, like, you know, they've just had a skin tear or something, you'd hand over what's happened, you know, any kind of relative history to the doctor.
Yep, that's true. So you're handing over that way, and it goes in reverse as well, I hope. The doctor's handing over someone back to you in the treatment room that they explain to you what's been done. So that's one example. Any others? Anyone wants to suggest any other occasions?
A specialist letter come back and say, could you review this patient? I've done this, this and this. Can you follow them up and send them to get a ECG next week as well? Or something like that?
So to document when you've had some recommendations come back from a specialist, what you've done and what the doctor or other parties need to do. So that's one, yes. Any other times that you would hand over?
Handing over to ambulance staff.
Yep, so if you're handing over to an ambulance, that's a classic time of handover. Any other times?
A regular clinical meeting once a week.
Yes, so at the meeting you might... That's right. What about when you're handing over, if you've got part-time staff, part-time nursing staff working in your team? Do you hand over what's been happening on your days to them? Do you have communication books or something like that where you might say, so-and-so's come in, you know, going to come in next week about something or whatever? Do you do that?
Send messages.
So you send messages, emails, whatever you want to do, that's right. So that's another form of handover. The other one is to your deputising services, your after-hours deputising services. If they see someone after hours, they'll send a letter back to your service, as does the hospital, etc. But if you have somebody that there's a concern about, it's usually expected that you'll hand over to your deputising service that so-and-so might be calling them over the weekend about such and such a problem. So that's your main areas of when you would, how you'd answer the interview. What about the documentation? Does anyone document that handovers are occurring? Would there be evidence in your service of documented handover occurring, or does it just happen and isn't documented?
For example, the one I did was it'd be in the holding file, so the doctor actually has to action it until the date that it was actioned when they saw that document.
So it'd be on the clinical records, and that's where most handovers are, but that, as you say, also your emails and things like that will give evidence of handovers.
The progress notes when you've been asked to do something by the doctor and as per doctor's request.
Yep, that's right. Yeah, so that's good. That's the sort of thing that they're looking for. Okay, next sort of area that they're going to talk about a lot is managing clinical risks. And as you can see, this has got the QI up in front of it. And these are some of the standards or criterion that are indicators that are there. You know, that your team makes improvements, that you monitor and identify and report near misses. I think it's important to actually first define what's the difference between a near miss and an adverse event. Anyone want to have a go at answering that?
Near miss almost happens.
Yeah.
Once you realise what was occurring before it actually, like, as it was about to,
Mm-hmm.
and an adverse event that's actually happened.
That's right. So everyone heard that. A near miss is almost happened, adverse event, it actually happened. So an example would be a near miss might be when you almost give somebody the wrong medication, and an adverse event is when you actually do give the wrong medication to somebody. So in your services, would you be clear, and is there an understanding around how you would report an adverse event or a near miss, the process for doing that? Anyone got a good process for what they do? Want to share with us?
Quality, it's called QMS, it's online, that's where all our policy and procedures are, but we can also report any incidences or near misses on there as well.
Okay, so that's an online system with all their policies and procedures there, and then they can report any near misses, which is a really great, very sophisticated system. Not everybody's quite as sophisticated as that. What about having an understanding of what constitutes a near miss, especially? You know, do you feel like what you report as a near miss might be different to what somebody else reports as a near miss? Do you think that there's been any discussion in your clinical meetings about what's been reported so that people get a feel or an idea for what is a near miss and what's happening? Anyone been to any clinical meetings while you've been employed where you are? Okay, so that's something that as a surveyor they're going to want to be able to see. They're going to want to interview you to see, you know, examples of specific events, and they want to see about the actions taken. And then they're going to want evidence of some discussions of the systems within your practice. So that means that they're going to be looking for people saying, oh yes, we all use this online system, or if someone answers it and says, I had no idea that even existed, well, that's not good, you know. And then the other thing, of course, they're looking for is documentation. So they want to see an incident register, they want to see a policy around it, and they will usually want to see records of team meetings. And so again, that's something that they'll be looking for. Here's some of the documentation evidence that they are looking for. They're looking that there's at least one member in the team who has responsibility for quality improvement, and they'll be wanting to see that responsibility detailed in their position description. They're looking for evidence in meetings and agendas, minutes. They want it as a standing item. So that also means if you're having nurse meetings, that you have it as a standing item on your nurse meetings, and that you are keeping minutes and agendas of those nurse meetings that you have. Because, you know, obviously nurses should be involved and invited to the clinical team meetings, but you may also have your own nursing team meetings and that you manage. They're looking for feedback surveys, and in general practice, they do a pretty big feedback survey of patients when they're being accredited, but they also want feedback surveys of staff. So that might mean when you've perhaps changed something, it doesn't have to be anything elaborate, it just has to be evaluating it, asking staff, do you think actually the changes we've made are working, they're any better or not? That's the sort of thing they're looking for. And they're looking for a quality improvement activity register. So here's the sort of question that a surveyor might ask you. Okay, they're going to say to you, give some examples of aspects of your practice that have improved in the past 3 years, including those in response to patient or staff feedback and those that use data for improvement. Okay. Anyone been working long enough that can suggest something that they've improved? You know, it's pretty hard to remember them when you just ask like that, isn't it?
Setting up the ACIR logons.
Okay.
For our practice, because previously they would just fax them to them, whereas I've got to set up on the online system and train the staff to actually use it.
So make a document that, because if you're not getting surveyed for another 2 years, you'll forget that you've done that, and it's really good. Like, that's a really good quality improvement. And obviously then that also uses data, and part of the standards want to see where you've actually used data. Anyone else got any examples of any improvements that they've done in their services, or aware of any improvements that have been made?
Due to some adverse outcomes of a procedure, we no longer do that procedure anymore.
Okay, so that's, yeah.
After legal issues and things like that, and we did review it to see where we went wrong.
Yep. And I like the way that you're using we in there, because that implies that there was a discussion with the whole clinical team around that, not just someone saying, right, we're not doing that anymore. Is that correct? Was there some? Yeah. And that's important to see that there's been discussion. So that's right. So you've obviously looked at what you're doing, thought it's not really the best thing for us to be doing. It's not in our scope anymore. So that is a quality improvement, even though it seems like you're taking something off, it's actually improving the quality. Okay. And one of the mandatory indicators that they will want is that you show evidence of a PDSA cycle every 3 years that ideally uses data. So there's something to be aspiring to. Okay. The next area that they look at is about patient identification. And so anyone want to talk about what we call, you have to use 3 approved patient identifiers. Anyone want to tell me what are considered approved patient identifiers? Let's see, we'll call them out. Name, was it?
Name, date of birth, address.
Yep, name, date of birth, address. They're the common ones. Anyone want to have a go at some others? There's not that many. Pardon?
Telephone number.
No, not allowed to use a telephone number.
Medicare number.
No, not allowed to use a Medicare number, because the same person may have different Medicare numbers. So that's why you don't use Medicare numbers. But you're on the right idea with a number. The last 2 are numbers, but they're not either of those numbers.
Driver's license.
No.
Patient number.
HPI.
Yep, a patient number and your health identifier number, which are neither of those are ever used in general practice. So the first 3 are date of birth, gender, address, and the main ones, and name, obviously full name. Now, what about when and why you would have to be important about checking patient identification? Obviously, any handover should involve patient identification. But yep, so if they rang up and wanted information, you'd obviously check their identification. And it can be a bit awkward because, you know, especially if it's a face-to-face consultation and you just saw the person 2 or 3 days ago, it's a bit odd to say, can you just tell me your name, date of birth and your address? And so one way to manage that is to actually explain to patients, have a sign up in your waiting area that we check this information to make sure that, you know, we're treating the right person. Why would you be wanting to ask that of someone all the time? What do you think is one of the biggest mistakes that happens in general practice if you don't check your identifiers?
Write notes in the wrong person's file.
Yep.
Give the wrong person medication.
Yep.
Or scripts.
Yep. Yep. Similar names are a problem, and writing your notes in the wrong file are the main thing that people do. They'll think that they've got someone there, and so it's important that when you ask someone to identify themselves, you actually check that that matches the notes you've got open in front of you. And it's becoming more and more important. And the other time that you need to be really mindful of checking identification, I'll tell you a story about my daughter. She went to this ENT specialist for years. She needed to get a copy of her notes because you know, she'd been a child when she went to see him and she was changed to an adult. She asked for her notes. Obviously, they asked for her identifiers. When the notes were sent to her, they were actually another person's same name, different date of birth and different age, but another person's notes were sent to her. So be mindful of checking anything that goes out of your service. So referral notes, have you got the right identifiers on there? Especially if people are asking for copies of their medical notes or histories, that you've actually given the right ones out and, you know, you're copying the right ones. And that's really important now because there's a whole lot of new legislation requirements around reporting significant data breaches, and giving out someone's wrong notes is probably classed as a significant data breach, and you would possibly have to consider reporting that. So, so it does happen. So next area that we're looking at is practice equipment. Okay, and this again, you can see that falls under the GP module. So they want to make sure that your practice equipment lets you provide comprehensive primary care, you maintain your equipment, you have one or more height adjustable beds, pretty sure everyone would have a height adjustable bed in their service now, that you have timely access to a spirometer and an ECG. Timely access probably means that somebody can get that when they need it, and also that there's not a prohibitive cost barrier to getting those things. And one of them is that you have a defibrillator, and that's got unflagged beside it because it's not required, but it is moving towards something that they are wanting you to look at. So let's have a look at what they are going to be asking you. This is assessed through a document review, so they're going to be wanting to see things like evidence of the maintenance schedule, log-ons, checklists, the equipment in all the rooms. They're going to do an interview to ask you, do you get this maintained, etc. And they're going to inspect the equipment, and most surveyors will usually look at least one doctor's bag. Now the standards have a really long list of everything, all the equipment you need, so that's all in there, but they'll look at one doctor's bag, and there's a set list of items that need to be in a doctor's bag. They'll also check if your height adjustable bed works, and some standards will actually check something else. Some assessors will check something else just to test you a little bit. I know when I used to go into services, I used to like to ask them about their oxygen, and I'd say, where is? Because often oxygen cylinders, it's a lot better nowadays, but a few years ago they used to just be like big heavy cylinders sat in the corner, like if a kid could pull it over on them, so it was a good chance to actually have a look at where their oxygen was. It was good to see if the cylinders were full, because quite often they were empty. And the other thing that was good to see is I'd ask the person to show me how they test the levels, and I'd actually see if the person who looked after actually knew how to test oxygen levels and that it was working, and check if they had a mask there that looked like it was used last year, etc. So, surveyors will have their things that they like to test you out on, and practice equipment is one area that they will often will often catch you out on. So, if you're asked here, how do you ensure equipment at your practice is sufficient for the procedures commonly performed? We're just going to work on this together, right? Pulse oximeter is required. So, if you have a pulse oximeter at your service, which I'm sure you all will have, how do you make sure that your pulse oximeter is sufficient for your procedures commonly performed? What does that mean? Anyone want to have a go at thinking? Yeah, batteries are charged, that's working, yeah. Anything else? I don't know if pulse oximeters need calibrating or not. Some do, I don't think they do much. So, but if there was a schedule in it, that you've got that logged in your schedule, that it's actually mentioned there.
They do test them every year as well.
Yeah. Yeah, so it's electrically tested, is that what you mean? Yeah. What else? What other things would you be looking
I
at?
put it on myself, and it said, like as I am now,
Yeah.
it said I was saturating 82%. I'd be questioning whether or not it was working properly.
Yes. You shouldn't be at 82% unless you're a pack-a-day smoker, that's right, and even then you'd be a bit worried. Okay, what else? What other ways would you be looking to see whether it's equipment suitable for the procedures that you do? Anyone else want to suggest?
Do you have different size probes for adults, children?
That's right. If you're seeing children, and especially if you're doing something like circumcisions or some sort of procedure, and even babies that come in with breathing things, you want to make sure that you've got probes that are suitable for infants under 12 months. The next thing that you would be wanting to also see is that it's being used when it should be. There's no point having the equipment and it's sitting in the cupboard, or somebody uses it in the treatment room, but actually the doctors don't come and get it when they might need it. So, you'd be wanting to make sure that staff know when to use it, and that if they're talking about procedures, they say, oh, well, I would get the pulse oximeter for this. So that's the sort of questions that they're looking at. The other thing that they want to see is that staff are trained in how to use the equipment. Now, I'm sure there's not a lot of training for how to use a pulse oximeter, but some equipment, there is a lot of training involved in how to do it. Your ECG, that staff know how to use it and how to turn it on, and that there's evidence of staff training in how to use it. So this is the sort of thing that they're looking for, and that you need to demonstrate. The other thing, of course, that they do look at when they look at equipment is expiry dates, and they always pick the expiry dates of like really random stuff like your sterile gloves and things like that. So just to give you the heads up, soap, cleaning agents, those sorts of things. So yeah, just be really thorough about that sort of thing. Okay, continuous and comprehensive care. This one, I think, the others are all things you need to do. This one, I think, is more of a high level goal or aim, just more of a vibe, I suppose. So rather than listing specific things to do. And it's a bit hard, it's not so tangible. So it comes out to things like patients can request their preferred practitioner, that our practice provides continuity of care and comprehensive care. Like, it's a bit vague, so what does that really mean? The way I like to look at it is that there's 3 types of continuity. The first type of continuity is relational continuity. So that's around a sense of connection between the patients and their doctors, and that is my doctor, my patient. The second one is around informational continuity. So continuity of information across healthcare events, that there's documentation, there's handover, review of notes from previous consultations when people come in, and also there's management continuity. So that's consistency of care by the various people involved in a patient's care. In other words, you're not working at cross purposes. You don't have one doctor say, do this, and another doctor says, do this. You've got some consistency and understanding about how you're going to manage common conditions. And you've got health summaries happening in there, and everybody's collecting health summaries, and everyone's asking about allergies, etc. So if you were going to ask how your practice promotes and encourages continuity of care, how do you think your service would promote any of those aspects of continuity of care? Say, let's say, for example, your informational continuity. So how do you think they make sure that you're getting consistent information across different healthcare events and handover, etc.? We've talked about that a little bit. What about in terms of notes from previous consultations? Do nurses get to see all of the care notes of everyone in your service now? Sounds like it would be so obvious, but back in the day when nurses were first starting, there were still some doctors like, oh, I don't think nurses should be able to read my clinical notes, which is silly. So you want to make sure that you can see all their notes. What about continuity between other on-site allied health providers that you've got working there? How do you go for communicating with them and what's happening there?
They leave notes, or like in the progress notes, or they also communicate that they've left something in there.
Mm-hmm. So in your service, those on-site allied health providers use the same progress notes. What about other services? Is there other services where they don't use the same progress notes? Will they use their own? Yeah. How does?
Scanning, I think.
Pardon?
They get sent to scanning.
Right.
And they get scanned into documents folder.
Yep. So they scan it in. Of course, there's letters, isn't there, that come in from different providers where people are sent out. So this is what continuous and comprehensive care is asking you all about. And they're going to be assessing that through some interviews and through looking at documentation. But I think it's a little bit more of a difficult one to get your head around and understand exactly what they're asking there. Okay, follow-up systems. First of all, if you've got a follow-up system, I think you have to define what is it exactly that you're going to follow up. So if you read these standards, they talk about following up clinically significant issues. What do you think of when they talk about clinical significance? What are you thinking of that you would be following up?
Results the doctor will want to discuss with the patient.
Yep, so clinically significant results. That's obviously not a result that someone's just having their cholesterol checked or something like that. It's probably something that is actually needs some actioning reasonably quickly. So it's not your preventative type results. So it's not all abnormal results really, but an abnormal result should be communicated. But we're talking more about clinically significant ones that are likely to have an impact on someone's health outcome in the near future. What other things apart from results are clinically significant that you need to follow up and make sure they occur?
Yeah,
Screening. So screening would that be clinically significant, your screening, or is it more fall under the category of preventative?
Well, if it's a follow-up for, say, they had a previous abnormality in a pap smear, say, 12 months ago, and they're due for their next one,
Yep.
it's clinically.
It's clinically significant, that's right, because it's clinically significant if they have already a diagnosis, for example, an abnormal pap smear, and you're doing a check. That's clinically significant. If someone's had a lifetime of normal pap smears and it's time for their next one, it's probably not clinically significant whether they come in and get it or not, and that would go on your reminder list rather than your recall. And it's really important to have this clear, because if you don't, you end up with such a massive recall list that you can't manage it and you can't keep track of it all, because recalls will ask you this in a little while what sort of things you have to do. What else is clinically significant? There's something else that we often do with patients that's clinically significant, and it often gets overlooked in the follow-up on recalls. No, not really, no. That immunisation, no, that still falls under preventative care, although you do work fairly hard to get them back for their immunisations.
So we're taking the right, like with, like say recall that you're doing the right thing if you can't get on the patient?
Yeah, that's part of the process. No, what is clinically significant is referrals. If somebody comes into you and they have a mole that looks definitely abnormal, and you send them off to the skin clinic to get that mole, plastic surgeon, then that's clinically significant, because until they've seen that plastic surgeon, it's actually the practice's fault to make sure the patient attends that consultation. It still sits with you till they've seen another provider. So referrals are also clinically significant events that need to be followed up. The other thing that can sometimes be also clinically significant is if someone's gone off for tests and they might have, for example, a lump in their breast, and they're going for tests to get a definitive diagnosis of what that lump is. So if you say to someone, oh, you need to go and get a mammogram, a diagnostic mammogram, not a screening mammogram, you need to make sure that person gets that mammogram, and so that's something else that's followed up. So these are things that need to go on these systems. So let's talk about what sort of systems you have for following up and recalling these patients with these clinically significant results. Someone over there was about to say, what are the steps? What are the steps in your recall system at your service?
We use HotDocs.
Okay, yep.
Obviously, HotDocs like sends messages and then a letter. We have to generate the letter.
Mm-hmm.
But we also then have to make a phone call as well.
Yep.
If it's not in the results, if it's not in the recalls,
Mm-hmm.
the doctor's sent a result through that wants to follow up, we have to do 3 messages or 3 phone calls and all that.
Okay. So anything else you have to do other than that?
Then we actually send an intramural back to our doctors then, letting them know that we've done everything we can do as nurses in reception, and then they have to decide whether the recall goes or stays or what goes next. So sometimes they might send a registered letter.
Yep.
Just depends on what they want to do.
So what they've got is a system, once something is identified and then entered into that system, there's multiple attempts to contact the person, and those attempts are documented. That's really the key aspect of it. You can't just ring someone at 6 o'clock every night, because they mightn't be available. You have to ring at different times. You might send a letter, you might send a phone call. So this all has quite a lot of time. The other thing then you document is that the person has responded and got that. The other follow-up to really close the loop is you need to actually make sure the person turns up for the appointment. There's no point saying, hey, come back and see us next week to get your results, and then they don't turn up. You need to actually, if they don't turn up for that appointment, have some way of identifying that that's significant, do not attend, and that they go back on the list and start again until they've come in. Or if they say, actually, I just don't want to know, I'm going to live my life in denial, that you document clearly that that has been said, and that you have attempted to send them information about the risks of living in denial. So there's a whole closed circle about it. Anyone else do anything that they think is pretty innovative or different? Because there's always lots of different ways to do this. Anyone got any systems that they think are really, really different that follow this up? Nothing special. It's always good. Sometimes people will come up with some really good ideas that they've come up with, especially if they're in areas with rural areas, or sometimes in areas working with migrant populations and things like that, because then you've obviously got to be able to speak to the people in their language and things like that. So there's often things like that to consider as well. No point sending someone a letter in English if they don't speak English. So again, they're going to look for interviews, ask the staff, they'll ask the reception, what's your job in this, the nurse, what's your role in this, and then they'll also ask them about they'll also look for documentation that it's happening. So basically, the things that a good recall system needs, it needs to have a practice policy written about it, and what you're doing needs to be the same as what the policy says. It also needs to include attempts to contact the person. It needs to show different times of day, needs to ensure that the patient attends the appointment, and it also needs to document no-shows. Now, we talked about reminders. This is your preventative care. There's no legal requirement to do any preventative care, but it is required under your accreditation that you do some. So, again, your preventative care for your reminders for things that are not going to be life-threatening, for things that are not going to impact on somebody's immediate health outcome or prognosis and are not likely to result in a legal action if you don't do them. So these are not so important, but often they are things that nurses are very involved in. It's about the using your data and systematically flagging people at risk of certain things, sending those sorts of reminders for them to come in for their care planning, for their other tests, you know, your diabetic cycle of care, that you're sending reminders about that. And it's very important that you ask for patient consent to be included on any reminder registers. Recall, it's a little bit more grey. You actually don't have to ask for patient consent to be recalled for things, but it's always nice when you're taking a result or a test that's likely to be something that you might have to recall someone for, to actually ask the patient, how would you prefer, if we have to contact you about this, how would you prefer if we contact it, just in case it's something a bit sensitive and they don't necessarily want someone reading their mail or whatever. So we're not going to spend too much time on reminder systems. Informed patient decisions. So again, you're asking, again, this is about how they receive information about referrals, treatments, and how they want that treatment and the management of their conditions. This, I think, is really important when you talk. They will ask you, how do you inform patients about their medical conditions, their treatment and management? And I think it's, sometimes you want to show examples of audits that you do in your service, and this is a really good topic to do an audit on. Let's think about the information that you might give out in your surgery for someone who comes in with a child with an elevated temperature. Okay? Do you know what information the doctors are giving? Do they have a little leaflet that they give someone, or do they just reel them out a few instructions? You know, obviously you need, for something like that, you need to be giving them verbal instructions as well as a leaflet or something in writing about what to do to manage the febrile condition. And then, is everyone giving the same information? Are people giving different information? You know, do you have a doctor that actually gives you the brochure that came from, that Panadol put out a few years ago, that just says take Panadol? Or do you have someone that gives you a brochure that is independently bought out, that has the best practice and the steps in what to do, what to look for, how to manage it, and then who to contact? And is that contact information current? You know, does that contact information say, contact the nurse on call line, or does it also say, hey, here's our deputising service number if you want a home visiting doctor? So I think it's really useful to actually pick a topic, have a look at the information everyone's giving out, and come up as a team with some consistent information that is actually of good quality. So, so that's just something that they will want to see an interview and a document of the evidence, and you can also then give that as an example of a PDSA cycle. Okay, the next thing that they want to look at is that you have a responsive system for patient care. And so this is looking at how you offer different appointment times to different patients' needs, and also how you, if you have a phone message that gives information about what to do in an emergency, and how you schedule appointments and manage emergencies if they come into the surgery. So let's start with how you accommodate different appointments. Anyone got any ideas on different approaches to appointments? You know, obviously you need to be able to give people long appointments, short appointments, appointments when they need it. What do people do to manage demand? Anyone got any strategies that they do in their surgery?
We have like certain slots that are blocked out for on the day.
Mm-hmm.
So if someone comes in, the reception usually kind of triages them before the nurse does, before the doctor does.
Yep.
So there's like, I think, per doctor 4 on the day spots.
Yep. So you leave some appointment gaps where you're someone who wants to come in on the day they can, and then what you said was really important, reception triage that, and it does fall on reception more often than not to make a decision about who takes those appointments, because you can't just give them to everyone that rings up on the day, or someone who actually might need them might miss out. What other things do you do? Anyone have anything like rapid clinics at their practice? Where does anyone use that model?
We have walking.
So walking clinic.
The Indigenous community.
Mm-hmm.
We're for them, but if we're booked out, they can still walk in and see
Okay.
the doctor.
So they have a walk-in for a community that's probably less likely to be scheduling appointments to meet their needs. What was that? Okay, so quick appointments, that's again what a rapid clinic's like. Do you just have one doctor?
We don't reckon clinics anymore.
Yeah.
Because we felt that didn't give everybody an opportunity to come when they wanted to.
Mm-hmm.
They
Yep.
were rural practice.
Yep.
And it was a large community.
Yep.
So some people wanted quick appointments
Mhm.
after 6 o'clock at night.
Okay.
There's no good having a quick clinic in the morning.
Yep.
Because the town's empty.
Okay. So, yeah. So you do it there.
And the girls all know
Yeah.
that a quick appointment means it's just a repeat
Yeah.
script for something you've already had,
Yeah.
or a repeat referral.
Yeah, and look, that's really good too, because then the flip side of that is it implies that if you're actually going to come in with your big long list, make a long appointment, because that's often a problem when someone does make a short appointment and they pull out the list and you think, oh no. After hours access are some strategies, and you obviously, as you say, you're open after 6 o'clock because that's when people have the time to come to the doctors. And of course, nurses will often run their own appointments and their own scheduling of those. So think about how you manage demand too, and make sure that those appointments meet the needs of people that come in. Next thing we're going to talk about is telephone triage. And this is, of course, the first step of someone ringing up and saying, hey, I need an appointment today. Now, the receptionist may manage that, but you may also be talking to someone around the triage, and often the calls get put through to the nurse and you have to then triage someone. So it can have its difficulties, because even though you know the person, you might jump to conclusions and make assumptions and not listen to what the person's saying. So there's some strategies there that you need to do if you're asked to take a telephone triage call. The first one is get their name, their age, and their 3 identifiers, basically, to make sure that you're talking to the right person. If they're very sick and someone's calling on behalf of the patient, then find that out and make sure that the patient is at their own home and not at someone else's home, because if it turns out that the call drops out and you need to call an ambulance, you don't want to call the ambulance to the patient's home when they're actually across the road at their neighbour's house. So find out where they are is always a good one if they're ringing with something urgent. And get their phone number in case the call drops out. You ask them to describe the nature, duration, severity of the problems and any recent surgery, and document all of that advice and all the questions and what you tell them to do. Ideally, avoid calling an ambulance on behalf of someone who's at home, because there's so many questions to go through, etc. You're much better to get that person to call the ambulance, and it's good advice to suggest that before the person calls the ambulance, they actually unlock their front door in case they, get worse while they're waiting for the ambulance, so that the ambulance drivers can get inside the house for the person. So you'll often get phone calls put through to you, and you're often rushed and busy, but don't ever just manage them quickly. They are things that can throw up all sorts of curveballs at you, and the important thing is have a process to manage them and document your advice that you give, and document the time that you took that call and what the advice was. Now, we talked about receptionists having to schedule appointments, and this is some flowcharts. There's a few different ones around. They're mostly, I've got one that I was going to get Jess to pass around to you. Just to give you an example, you can get these online, you can buy them off your PHN perhaps if you talk to your PHN person where they're available. But what they basically do is they give people a guide. They guide receptionists with the questions to ask, and they help reception staff determine the urgency of something. So is it something where I need to, for these ones, call 000, or do I just need to get the nurse? For these sorts of ones, do I need to get the nurse? Or for these other ones at this end here, do I tell them you can make an appointment in 24 hours? You actually don't need to use our 4 special appointments we save for you. So the one that's being passed around, and a lot of these also have a little booklet that goes with them. You'll often see these pinned up on the walls at reception areas in medical practices. The booklet's designed to go in the treatment room, because a good triage system, it needs to work when the nurse is actually not present. And so often Saturday mornings there might not be a nurse working in your practice, so the reception staff need to know what to do and what sort of basic first aid things to do, so they don't give someone who comes in with stomach, abdominal pains a drink of water. It's just very simple and basic information, but the booklet does actually help add to the safety of it, because it just tells them basic, sit someone up, don't leave them, this sort of very basic advice that will help. And it is part of accreditation that you demonstrate that you have a system in place, that there's evidence of something in writing, and that people know how to follow it and that it's used. So that's an example. You can always write your own if you want to for your own service. And obviously for country areas it may well change. Calling 000 might not be all that mightn't be the best option when your ambulance is nearly half an hour away. You might be better to say go to your local hospital or something else. So things might have to change. Okay, other areas that are covered in your accreditation are vaccine potency. I'm sure you would have covered this off when you've done your immunisation and vaccine part of this training, so I'm not going to go into too much detail, but just for you to know that there is indicators around how you're storing and managing your vaccines, and it's mainly linked to the potency of the vaccine and the storage of the vaccine, not linked specifically to administering the correct schedule. So the accreditation standards are really all about vaccine storage. And there's more of it, and again it's interview and document, so they'll obviously want to see that you're monitoring your fridge temperature, etc., and that you know that. The other area that they have information about is infection prevention and control, and this includes sterilisation. Next session we're going to go into a lot of more detail about this, but what the standards do require is that you have at least one clinical team member who has primary responsibility for various infection prevention and control standards. So really that normally falls on the nurse, so we're going to talk about what that role looks like in the next hour or so. And again, it comes up there as well, the same thing about this clinical team member who has the responsibility for education. Now, most of you have just started new in a practice. Who has, when you got there, who went through their induction process and were actually given really good information about infection control and prevention? Someone's got their hand up. Anyone else? Yep. Did it involve competency testing? Did it involve actually saying, hey, if you've done this before, can we watch, if you've sterilised somewhere before, can you show us how you operate we've shown you how to operate the steriliser, now you show us. Any competency testing involved in your orientation? Okay, and any discussion about what education you might want, or what you know and what education you want? So someone's nodding. Anyone else? So that's good. If you didn't get that, then perhaps you need to be thinking that whoever is the person with designated responsibility in your organisation, and can you all name that? Were you all told here's the person that does infection control, or were you told now you're the nurse, that's your job? Anyone know?
After accreditation.
Hey?
I only found out after accreditation.
Okay, so you asked the question of accreditation and you need to know the answer? Yeah. 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 So
I had as many buddy shifts as I wanted.
what was that?
I had as many shifts with the other nurse as I wanted. They said, just tell us when you're ready to be on your own.
Yep. So
Then we'll support you
Yep.
to be on your own instead of,
that's really good.
2 weeks worth of shifts with the other nurse.
Yeah.
And then I was on my own.
Yeah, so that's really good, and that's also involves obviously assessing your competency, because the other nurse can see by working alongside you how you're going. Yeah.
I watched her do things for the first time, and then
Yeah,
before, I think we crammed a lot into all
yeah.
that.
I think everyone's envious of you in this room. They're thinking how lucky, because often that's
We
not.
crammed a lot into the last week, like using
Yeah.
the steriliser and stuff
Yeah.
like that. And if there's anything I'm not sure of, they both gave me their phone numbers so I could call them.
Good.
outside hours.
That's really good. So that's a really good system. That doesn't happen everywhere, but at the very least you should know who is the person that has a designated responsibility. And as I said, if you weren't sort of given proper orientation and induction and checked what you knew and etc. for all areas of nursing, then, but especially your infection prevention and control, then perhaps you need to suggest that you might be a better person to do that job. And then the other thing, there's more here about sterilisation. For those of you that sterilise on site, there is a requirement in there about recording your load number and barrier systems, etc. It's unflagged, so you don't have to do it, but you will find a lot of services are starting to do it. And obviously they think infection control and prevention is important in accreditation, because there's more there about the sort of questions you'll be asked is to outline your responsibility for staff education or infection control. This will be asked of the person who has a designated responsibility. So this is obviously why after accreditation at your service they appointed somebody and you found out who it was. So these are the sorts of questions that they will be asking. Okay, there's some new requirements for the 5th edition. I'm not going to go into a lot of detail about them, but just to say that one thing that with the new requirements or the new edition, I actually think that they let practices develop their own processes instead of being quite as prescriptive as the old ones. So the old ones will say you have to do it this way, whereas the new ones, it's just more a little bit about you look at what you want to do. So when you're reading the standards for the criterions for the new ones, they have a good explanation about why this is important or why you should do it. Read that, because that will help you realise and guide you in how you might do it. You know, the reason why you're doing it actually helps give you ideas in how you might do it. And they also use the word must or could, and it's important to have a look at that, because obviously could means you've got a lot more flexibility about whether you even do it. Must means you have to be doing it and you have to be showing that you're doing it. So that's just more about the new requirements. I'm not going to go into them in too much detail, because really if you're going for accreditation you'll read them all then, and I think you've had a bit of a taste of the sorts of things that they're looking at and how an assessment process would work. Here's some key messages. So nurses do play an important role in developing and maintaining your quality systems, and accreditation is one of those main systems and one of those times when it's the focus of the practice to be looking at quality. So it's a good time to, as I said, put forward ideas that involve quality. Accreditation involves all practice staff. If someone's saying to you, hey, can you just do all this and tell us what to do? Don't buy into that at all. You say, no, this is something that everyone has to be involved in. You need meetings, you need teamwork. You cannot, as a nurse, do all the accreditation for a service unless you've got buy-in from everybody else. And it is a good opportunity for the nurses to show leadership. There's some websites that you can go to and some ongoing reading and learning. The main ongoing learning there is if your practice is going for accreditation, make sure that you have a look at their report from their previous accreditation cycle, because any of the recommendations made in that report, if they were required, then they would have been done. But the other recommendations, when they come and reassess you, they'll want a bit of an explanation about whether you did it, and if you didn't do it, why you chose not to do that recommendation. So it's worth getting your head around what the recommendations were when you were accredited the first time or the last time. And that's about it. Thank you.